All right, I'll go ahead and get started. Hi, everyone. I'm Jana Goldberg. I'm a medical director for Heartbeat Health. I am super excited to be here with you today. This is the first of a two-part series in virtual cardiology hosted by Heartbeat Health in collaboration with the American College of Cardiology. Today, we are talking about Virtual Cardiology 101. We have an amazing panel with us here today and a great turnout, several familiar faces, and happy to see some new ones as well. Before I introduce our panel, a few housekeeping items. So our webinar is 45 minutes long. We'll spend the bulk of the time with some key questions to generate panel discussion, and then the remainder of the time we'll go ahead and open it up to audience questions. If you have questions along the way, please feel free to go ahead and ask them in the Q&A chat, and we'll save them for the end. Since we have such a large audience, we prefer that everybody uses the chat Q&A as opposed to raising hands, just so we make sure we don't lose anyone's questions. We have a great group, and I am excited to have you here. Please don't be shy and ask away. So I'll go ahead and I'll introduce our panel. So first I'll start with Dr. Ritu Thamman. Dr. Thamman is an assistant professor of clinical medicine at the University of Pittsburgh. She serves on the board of the American Society for Echocardiography and has a heavy involvement with the American College of Cardiology. She has a particular focus in women's cardiovascular disease and has also has really become an advocate for women in cardiology, starting the Women in Cardiology chapter of PA in 2017. She's also become a valuable innovator in the virtual cardiology space. So it's good to have you here, Dr. Thamman. Dr. Bhatt, thank you for joining. It's great to see you as well. Dr. Bhatt is the director of the Adult Congenital Heart Disease Program in Outpatient Cardiology at MGH. She's been an innovator in the telecardiology space and adopting mobile health technologies to bridge gaps and provide top-level care for all overcoming social determinants, geography. She's also a clinical affiliate with the MGH Healthcare Transformation Lab and advises around the country in the virtual cardiology space. So it's good to have you here, Dr. Bhatt. On a personal level, I feel fortunate to have worked with Dr. Thamman and Bhatt as part of our partnership with the ACC through the Innovations Committee. And on behalf of the group, always look forward to their insightful feedback. So good to have you here. Dr. Phillip Duncan, as well as another panelist, we're so happy to have you here. He's founder and medical director of the Cardiac Health Management Network in the Richmond area. And prior to that was medical director of the HCA CJW's Advanced Heart Failure Program, serving as medical lead on the first LVAD implants there. He's active in his community, speaking on reducing cardiovascular risk, reducing disparities in cardiovascular outcomes. And also on a personal level, Dr. Duncan, our group has gotten to know Dr. Duncan very well through his virtual care experience and in pushing healthcare innovation in his own practice. So with that, great to have you all here, and let's get started. So the first question, I'll start with you, Dr. Bhatt, and then I'd love to hear from Dr. Thamman and Duncan. Virtual care looks different for everyone. What does virtual care look like in your practice, Dr. Bhatt?
Great, thank you for asking. So virtual care for us started in 2013. So we started a long time before the COVID pandemic. And the way we initially started was actually doing a review of patient data. So it was an opportunity for us to really educate the patient better by deciding to show them their images instead of just send them a report of an echocardiogram, for example, or call them on the phone and say, hey, everything looks okay. And so that was a very nice and slow introduction to how to use telemedicine. That, of course, has evolved to the point where now we actually frequently will use it for follow-up visits. We'll use it for new patient visits. We'll also use it to be able to take a look at people who need triage, people with clinical symptoms, and then decide what kind of care do they need, where do they need that care, what kind of testing should go on along with that. And so, right now we're using some asynchronous care in electronic consults. We're using patient-reported outcome measures. We're doing the synchronous care that we just talked about. And I think the next steps for us are really saying, hey, in addition to having this kind of a platform, what are the additional things we can use? How do we get those vital signs, single lead EKG, into our routine care? And I think that's really important and really the next direction that we're going in. It may help all of us if the rest of us mute while one of us is talking. I do hear some feedback. I hope others don't.
That is better. Thank you, Dr. Bhatt. Dr. Thamman, how does virtual care look like? What does it look like in your practice? How's it similar or different from Dr. Bhatt's experience?
Thank you, Dr. Bhatt. I agree. And we have also been doing telemedicine now for a number of years preceding COVID-19, starting with just having a cart with a computer to do video visits. And that was really the start based on the rural population of Pennsylvania, which is enormous. And the fact that we were trying to make patients' lives better by not having them drive 3 hours just to come in for a checkup. And that was really the start, the impetus to begin with these sort of rudimentary kind of things. And we started by having a nurse at the site where the patient was being seen, and they would facilitate the video visit. So the patient would come into their local place, and then we would have a conference or a consult, even though we were hours away. Now, after COVID, and certainly having accelerated all that, now the video visits are embedded into Epic, and people are getting much more comfortable using that, I'd say, from the provider side, the doctors, and realize its potential, even though from a business side of view, I think there is the facility fee that is not sometimes captured. And so now as we transition back into more of a, less COVID cases, certainly in Pittsburgh, we have less COVID cases. There remains to be seen, like, how much of this will go back to just inpatient versus staying with not only the video, but then how do we incorporate the remote patient data into the visits. That has not been seamless because of the problem of interoperability. So that's still an issue. The other thing is getting the teletriage, the algorithms for different types of complaints. We're working through that, and it's not 100% yet, but certainly we're trying. So, for example, if we see a patient who has AFib or congestive heart failure, that those algorithms are pretty tight, and that we could facilitate between learners how to proceed in a real systematic way. So those are, it's sort of like building the airplane and flying it at the same time. That's still happening now, and it's still accelerating.
Yeah, absolutely. Thank you. And Dr. Duncan, how about for you? How does virtual care look to you?
So for me, being in really a community practice, at least that's the majority of what I do. The other, about 1/4 of what I do is actually at VCU working wards. But in community practice, COVID really drove our move into virtual care. We had made some minor forays into that in the past. However, with COVID, it sort of made it necessary for us to come up with a way to keep up with our patients, to maintain that contact. And so we've done a very quick learn on how to triage patients, see patients virtually, and do our follow-up. The biggest thing that I've learned as we've moved forward in this, though, is that the vast majority of what we do as providers is around behavior change. We're trying to encourage certain behavior changes for our patients, whether it's compliance with medications, diet, exercise, follow-up. And what I found is that the virtual visit actually is an outstanding platform for teaching. As we've worked on this more and more and worked more and more on how we triage our patients coming into the visit and then plan what happens after the visit, I found that most of the time I spend on a virtual call is actually spent on going over instruction, teaching, description, and I've really been very, very pleasantly surprised by how well that works.
Yeah, it's fantastic. And I think that's really a huge piece of it, right? Because it's not really just the telemedicine, it's the telemedicine or virtual visits, plus components like remote patient monitoring, plus patient education, that really, as a whole, we start to see change, right? And so I think that's fantastic that you've made that your own observations in that. Dr. Duncan, how do you integrate virtual workflow into your week? Is it a daily practice? Is it kind of between your face-to-face visits? Do you block out time? I'm interested in hearing your thoughts and then the rest of the panel as well.
Well, we started out trying to integrate it in the regular days, and that really did not work out as well as what we've now, when we has morphed into telehealth Tuesdays and Thursdays, and then Friday as a hybrid. And I found it's just been much, much more efficient for us to do a series of telehealth visits one after the other. And we found that doing that where my staff triages the patient first, then I do a telehealth visit, send a message back to staff to do a follow-up. They do a follow-up visit. By that time, we're moving on to the next patient. And so that's worked best for me after trying it, in all kinds of different iterations.
For us, I think initially it's much easier to try to just do block time when you're learning. And I think that's been shown in studies as well. And then we're able to go into some kind of hybrid where you can go from virtual to, going to see a patient face to face. But it takes some getting used to be able to go back and forth. And once you become much more agile, I think starting with block time is probably your best bet.
I would agree. We tried to do the interspersed when we were not familiar with flow, and it actually made people rather unhappy. And so block time is better. I will say even now, I've done some in person today, some virtual, and then given some presentations, right? It's, all of life coming together in one day. The challenge with in-person clinic is the control over the timing. And so I do think that it's still challenging to try and kind of insert the virtual. I do love it for virtual urgent patients if I really want to get a sense of what's happening with somebody, but I don't want to necessarily find a space to bring them in, nor do I just want someone to call them on the phone, just I want to connect. That's actually where I've found it most useful to kind of use virtual urgents in the middle of other types of days to be able to help me triage what am I going to do with this patient and what comes next. And the patients really appreciate that as well, because that's their moment of need. And there is something about that human connection, especially without a mask, that people really like.
Yeah, absolutely. And that gets to kind of my next question, Dr. Bhatt, is that idea that you can see someone quickly virtually and what effect you've seen on patients. So are there specific cases in mind that arose that you think a patient perhaps really needed that virtual visit, where you felt like it really made a major difference in their care?
Yeah, so it happens almost every day. People really appreciate the availability. Contrary to fears, patients are also very understanding about your availability and very grateful for your ability to kind of come on quickly and don't expect that per se. And so I think, some people worry about that level of access. I don't think that's something to worry about. I'll give you a different example than what you're kind of asking for. So yes, it's helpful to see somebody, see whether they're sick or not sick, and figure out what to do. I was actually just talking in a presentation about a patient I had who needed a fourth time redo surgery. A young patient with congenital heart disease who is now an adult, dad of 2 kids, wife at home. And I said, come on in, we have something important to talk about, because that's what we do, right? That's what we do as physicians, hold their hand, sit in the office. You don't tell someone this over, it's like breaking up over text. You don't do that. Like you tell somebody face to face that you need their 4th surgery. And he actually pushed back and said, no, Dr. Bhatt, I know you do televisits. I need to be at home with my family because I have a feeling I know what you're going to say. And I really need to be there with them when I hear this kind of news, because they're what's going to get me to do this and get me through it. So I'll tell you the ways in which people and patients appreciate the use of telemedicine. You can't predict it per se.
Yeah, it's amazing. They're really, I think those who haven't really dived into the space as much, perhaps may not appreciate that connection that you can really get, both in terms of information gathering, but just that difference that you can make in speaking to someone. So that's a great story. And Dr. Duncan, I know you mentioned a story another time to me, and an example that made a big difference for a patient. I would love if you could share that with the group.
Yeah, and this was actually not a scheduled televisit, but a patient who I initially spoke to on the phone at night after hours, and just didn't sound right to me. And he was actually out of town, so we had downloaded the app when he was in the office. I said, yeah, let me see you. Let me get you on the app. Clearly, once I saw him, he was in a fair amount of distress and actually ended up being hospitalized. I sent him, was able to direct him to a local hospital where he could get appropriate care. But, it was one of those situations that, was just proof positive to me that there are times when if you can't be there in person, virtual is helpful. Visual virtual is the next best thing to being there in person.
I would agree with what has already been said. And I think that some other examples of where telemedicine is just super is sometimes patients are in situations, your own patients, that might require a second opinion. I'll give an example. I had a patient who was admitted to a community hospital for mitral valve repair and was in the ICU with a complication and really needed, a second opinion. And I was able to do that via telemedicine. And he needed a redo surgery. I mean, it was a life altering decision. And I was able to even look at his images via telemedicine that were done at this hospital, the TEE images, and realizing that he had SAM and from a complication from his surgery, from his repair. And then we were able to facilitate him coming in to getting a redo surgery at, a tertiary care facility. That was something that, that would not have happened pre-telemedicine. So there's all sorts of use cases that we're identifying, just like Ami also mentioned, patients who you can slip in between your other visits that are scheduled. I think that's a real big positive, especially when patients need it the most. Just a connect face-to-face video, makes a huge difference, and you can put your eyeballs and really see the patient, makes an enormous difference. Of course, that leads into your, some of your other questions, the next question, which is not every patient has access to video. And that's where we really need to do better as a community at large in the United States, and have broadband and have that access for everyone. And I think probably all of us have had that experience where, you lose connection, or the connection is so bad with your patient and you have to go to phone. and you know, you're trying to glean information and it's not always adequate.
Yeah, I think that's really, I think it's really good that we're saying, I love hearing you say that out loud, because I think that we're not hearing that enough, right? I mean, at COVID, one thing I think that that has been made apparent is that with the, with COVID and the ramping up of telehealth is, that there are these barriers in virtual care, on the patient side, on the provider side, particularly socioeconomic barriers. How, I think you had sort of led into that, but how do you think we can overcome those barriers?
Well, ideally, we would have either just like we pay for parking for patients, we would give them, a card that says, here we're paying for your broadband access for those who do not have it. And ideally, even beyond that, if they have insurance, whether it's Medicaid or anything, that should be part of, the intake, like what is your speed of connection, and offer sort of almost like we have coupon, we give coupons for food. I mean, this is like just as an important entity, because without that, we can't really do the right treatment plan. And so I think that those are going to be some things. Of course, the FCC is, I think, trying to, give money and have that, but there's a lot of political infighting that has prevented that from happening thus far.
I think what Dr. Thamman's saying is perfect in the way we think about that access, right? We're coming at it from, telemedicine or telecardiology, but I think the real question is, what do people need to be able to function in current day America, right? Like are the basic necessities? And the way a majority of the world is going during COVID, the way education and healthcare are both going, it's a basic necessity. And I think that's where the government does have a role in ensuring that those basic necessities are provided in some way, shape, or form such that we can use them. And so I think, the telemedicine community who's watching this or watches this in the future, I think that's why that is our role, to say, hey, we need people to kind of step up and help support that. And we have HR 133 and other things that are supporting it, but I think we can continue to push and make sure that we demonstrate outcomes that also, help give them some fodder and some reason to be able to do that.
Yeah, absolutely. It's absolutely applicable, not only to healthcare, but to education. Dr. Bhatt, what kind of outcomes do you think we'll be able to show in the virtual space? What do you hope that we'll show?
Yeah, so the balance that we strike right now is a frustrating one, because it is a balance between fee for service and value-based care. And we are still one leg in each canoe. And so when you're looking at what outcomes look like, we can most certainly look at successful adoption of telemedicine, but we don't know if that's going to improve outcomes yet, right? Necessarily. We can then say, well, successful adoption of telemedicine with clear outcome improvement in select subgroups using a specific kind of telemedicine, using a specific group. And that's the research that's already been done and continues to be done. However, we probably need larger, nationwide, multi-center registries where people come together instead of publishing single center work, which, I'm also at fault for doing because we publish what we can, right? But coming together and saying, in a value-based care model, here is what we would have achieved. Here is the guideline-directed medical therapy. Here are the number of patients who stayed home instead of came back in. Here's what that looks like with implantable devices. Here's what it looks like with wearables. And at the same time, unfortunately, I think our research is also going to have to say, and by the way, here's the cost of offering that care, and here's the cost, saved by offering that care. I don't think we're going to get away with not doing both until our country figures out which direction we're headed in. And for the foreseeable future, I still see us with a foot in each canoe for a very long time. So I think I'm saying we need to do it all, but I am saying we need to do that with larger volumes of patients and with clear goals about what we think is a good outcome. And some of those are hard outcomes, but others are things that we never achieved before without the use of telemedicine. We can't reach every cardiologist in the country to ensure that they are implementing guideline-directed medical therapy for ASCVD or heart failure reduced ejection fraction the way we are right now with telemedicine. Actually, we probably can. And so I think those are the kind of wins, right? Crossing that finish line that we want to achieve.
Yeah, I just wanted to sort of weigh in. I guess again from the smaller community practice side, I think that your point about how much can be saved by adopting it, I think that shouldn't be lost, because when you look at just the total amount of resources that are spent that don't positively benefit patient outcomes, I think that we need to look at and explore that a lot more heavily. And my sense is that the amount that we can save, improve outcomes, and also save would be tremendous. I've looked and seen the figure $84 billion to provide broadband to everyone in the United States, and that's probably cheap when you consider what we would save over time. But one thing that I find is sort of a separate challenge is the digital education. How the idea. Now, I've got patients, for example, who have access to broadband, and their kids or grandkids have set them up so they have the internet, or had to talk some of them into going from their flip phones to their smartphones. But we also have to look at ways that we can provide education digitally to folks so they know how to use this technology, because it's a little bit more challenging than the microwave. And the other piece is, as innovation comes in the technologies, it actually makes that piece easier. And that, for example, when I use this particular app, what's made it beneficial is just the fact that the increased ease of use. So we do have to look at that. If we have the broadband, if we have technology, folks have to know how to access it and utilize it.
I agree with that. And I think also points to what has already been mentioned. One is, we have all this potentially collective data, but they're all in separate entities, as Dr. Bhatt was saying. We don't have that interoperability of our data, like the hospital systems don't talk. And until that's legislated, probably there's no financial incentive for hospital systems to share data, even though we potentially could, use all that to improve patient outcomes. There's a disconnect there, certainly, still. And, but, we remain optimistic. And the other point is that those endpoints, normally, when we look at outcomes, we want to look at mortality data. That's the most hard endpoint, but, we're not going to be able to show that. So we need surrogate endpoints, and those are still being worked out. Like, what are the ones that are really relevant and improve, quality? These are very tough to pinpoint and to implement. And I think that we're in those processes of making these iterations so we find out using telemedicine, like what are those things and methods that we should really be using to get this data in a quicker time, say 6 months time to a year, so we can give that to the policymakers, so we can give that to the payers, and then, have it be more validated and paid for.
Yeah, absolutely. And along those lines, since Dr. Thamman, you brought up the idea of having data, we're getting a lot of data, right? And remote patient monitoring, for instance, has become a hot issue over or hot topic, I should say, over the past year. There's some data to support that RPM in combination with other things such as education, risk stratification, and virtual visits or more frequent touch points with patients may improve outcomes. Do you utilize remote patient monitoring? How do you ensure it's effective if you do? And how do we identify patients who may benefit from RPM?
I think they're great questions. I think RPM has been shown to improve patient outcomes, certainly in the space of postpartum hypertensives and in regular hypertension patients. And I think everyone could benefit from RPM, because that's really the point. And that's really the most growing sector of what is under the rubric of telemedicine. Because that's where we can have this continuity of care rather than sort of parceled out care when it's face-to-face or video. And that's really where we make the next leap into much better outcomes, because patients need those nudges. And we've shown through behavioral economics that if you have small touch points during the day, and that frequency can vary based on your patient population that you're reaching, that can make a tremendous impact in whether the patients adhere to their medicines, whether they really are understanding what you're saying. And the fact, it almost feels like every single little interaction with RPM may be another touch point that the patient feels, my physician cares and is trying, even if it's, through a text message. But that's really, really important.
I love that. And I love just the idea that even just tiny interactions really build on that patient-provider relationship. I want to ask one other question to the group, and I'll throw this out there to everyone, because I also want to kind of focus on the provider side for a moment. So the statistics on physician burnout are really sobering. And I think it's important that, we all kind of talk about this as a community. And I'm interested in hearing what the group thinks on what effect virtual care will have on providers.
I think well-organized virtual care with supported workflows is excellent. It gives clinician flexibility. It gives you power over your own schedule. It allows you to connect with your patients in a way that's very human. It takes away that divide of the patient in the blue gown in the sterile room, and really, rejuvenates you with the relationship that is that patient, the patient's family. Also invites you into their home to an extent, and so really allows you to see the patient as a more of a holistic individual rather than a number, which none of us want to do, and yet that can happen over time. However, without workflow, without support, with just saying, hey doc, go see a patient virtually, figure out what platform you want to use, and best of luck getting their data back, that's incredibly stressful. And I suspect, and I hope that we can figure this out over time, but I suspect that a lot of the people who went running back from virtual to in-person as soon as possible, those practices that shuffled back, were ones that didn't develop an infrastructure, either didn't have one coming in, as some of us in larger programs are lucky enough to have, or didn't really buy into the infrastructure and support of their clinicians during that COVID period because it was challenging. And therefore, without a support or infrastructure, of course, you're going to go back to the thing that makes more sense. So I think that workflow or infrastructure is essential. And when that works, the ability to choose, right? The autonomy to choose. I think this patient needs a virtual visit. I think this one needs in person. The possibility of doing blended care, there's nobody's going to say no, because no one's telling you have to do 50% virtual. We're saying in any given practice, on one day, you may be 90% virtual, 10%, you may never, you may always be between 5 and 15% virtual, but that's okay. But blended care and physician and nurse autonomy, I think if we can achieve that, virtual care will make an incredible difference in the physician burnout, physician engagement, nurse burnout, nurse engagement that we're seeing right now.
Yeah, I just wanted to really, you said it all. It's really ditto that, the protocols are important. Having the support is important. But when I look at what the future offers, the beauty of digital care is we have the opportunity to do both population management by having large amounts of data, along with that very personalized care, finding particular points, finding people at the point where they actually need you, and intervening then with those messages. So I think that's rewarding, because that's why I think most of us went into medicine. The other potential for this is that we can utilize expertise, and it doesn't necessarily have to be in one particular location. So I can see a future where, if I need to see for a patient to interact with a specific type of dietitian, or one I think they're well matched to, I can match them to somebody who is here in my hometown or in Seattle, Washington. I think there are tremendous opportunities for us to provide best care utilizing these tools. And it's just a question of, is there a will and a movement towards it? And, I guess being somewhat of an activist, I think as providers, we have to push for that, because it's not going to just naturally happen.
And I'll add to what's already been said, which is, I think these points that have already been made are extremely important and valid. But there is this minor issue that there is this thing called facility fee. And many practices are being sort of urged to, well, see that patient in person, when you know very well that you can see that patient via telemedicine, but they're trying to get the facility fee. And when we have this division between the price points, there's always going to be that conflict. Most of these systems, our healthcare systems, are trying to make, money, even if they're designated non-for-profits. So I don't know how that's going to be resolved, but certainly many people are under that constant pressure. And I think that that's something we have to acknowledge, and moving forward, figure out how that's going to be more of an equitable solution, so telemedicine can really thrive.
Yeah, and perhaps as we start to show outcomes more in the space, right, we're able to work as a group more national level rather than kind of siloed cohorts. We're able to show some outcomes and maybe make the difference that way. Okay, I have a few questions, and so in the interest of time, I'll jump into audience questions because I want to make sure we get to them. So these are all directed to the group as a whole. So I'll start with this one. How do we use remote patient monitoring or single lead ECG? So what can we monitor remotely? How do we do that?
Well, certainly blood pressure has been monitored for many, many years, and there's outcome data for it. The AFib space and picking up arrhythmias like AFib is newer, but also there are some outcome data, especially something called telecheck AFib that was started in Europe, and it's 47 centers, and it's app-based. And they've been shown to be, showing that the patients have less morbidity associated with those using that. Of course, it's going to vary on the prevalence of the disease. So if you're looking at all comers of AFib, like they did in the Apple Heart Study, that was very low yield. But blood pressure control, like half the population has blood pressure problem, that is clearly, an area where we can make a huge impact. And then therefore it's a cascading effect, because if you can improve blood pressure, you're going to reduce strokes and congestive heart failure, AFib, everything else downstream from that.
Yeah, absolutely. It seems like it's really two categories. One is sort of the primary prevention and capturing the appropriate screening group who should be enrolled in something like that. And then two, the patients who already have it. All right, a couple of questions that are very similar. One from one of our audience members. I've been using an electronic stethoscope for consultations and follow-up visits on patients in rural areas. With the expansion of telemedicine during COVID, I'm now doing some virtual visits without the benefit of an electronic stethoscope. Can you comment on your experience with and without the ability to auscultate during a virtual visit?
Yeah, so I love virtual visits. However, I'm at a point where there's certain patients where I really wish I had a stethoscope on them. It's interesting, it's not exactly for that moment. For many, I take care of adults with congenital heart disease. Many have imaging studies. I already have an echo or an MRI or something else. But the main reason that I would want a digital stethoscope there is for the interaction with other physicians, for the continuity of care long-term. Just right now in general, when we use a digital stethoscope, when we use a regular stethoscope, it's not a great communication tool. I hear something and then I try and write down what that means by saying 2 out of 6 systolic ejection murmur, right? And then somebody else listens and I don't know that they're hearing what I'm hearing. So as a communication tool, I don't think we do a good enough job. We take a sound and then we try and verbalize it and then assume that somebody else understands that. And it's a really big assumption. So I think in general, this is our opportunity to improve upon auscultation, period, by using digital stethoscopes such that we can record the sounds and not only hear them, but see a phonogram and eventually use algorithms to measure that and really say, oh, look, I'm looking at a phonogram of mild aortic disease, but 1 year later, that sure looks moderate. Look at how this has changed. Look at what the algorithm tells me. And my ears confirm that, or my colleagues' ears in Maine confirm that while I'm in Boston. So I see the digital stethoscope as a real opportunity for us to take telemedicine to the next level. I think it's a must. I also see it as a way to correct a fault in our system that we just never wanted to admit because I'm a cardiologist and I love the stethoscope, right? But you have to admit, even for teaching, I don't know that my fellows are hearing what I'm hearing. I'm hopeful, but unless I'm making them draw it out with me, you know, which I do make them do, I think it's really helpful to have this for education and just for better care.
Yeah, I think also that there's a twofold part to that. I think digital technology will be very helpful for us when it comes to standardizing what we hear and utilizing that data. The other part and the benefit and the reason why I think we'll never totally give up in-person visits is because in reality, I think our in-person physical exam adds that other aspect, that human basically touch, seeing patients, you know, how patients respond, you know, on a continuous basis, you know, feeling the pulse. I think that there's something to that is sort of separate from what digital technology can provide. I think digitally, we can actually, at this point, we have the technology and we can refine the technology that we can acquire data that's much more useful than what we get with our traditional devices. However, that physical, you know, we still haven't overcome that barrier of physical touch. Okay, I'm putting my stethoscope on your back, listening to your breath sounds, you know, getting a feel for how anxious you are or whatever. That those things are still there. And so I think that'll still be a part of what we do. But the vast majority of what we do, we can acquire in other ways that are far more reproducible and able to be evaluated.
And just expanding upon what has already been said, we have point of care ultrasound with AI capability such that the patient can actually potentially just examine themselves and give us an image, which will give us, you know, the S1, S2, because you'll be able to see it. And, you know, there's a question from Mark Hansen asking, you know, what is it going to look like in 5 to 10 years? And that's where maybe there's going to be kiosks. Maybe there are going to be these POCUS where you go to the library and you have a room there in a public space, you know, a shared public entity like a library or a university or a community college. And you can have, you know, rent the POCUS or use the POCUS, a device or a stethoscope. And, you know, the patient can examine themselves and then that's part of the visit. I do think that that's here because the AIs will help so much in terms of being able to guide a novice in using these to help give us that clinical information in the moment.
Thank you, Dr. Thamman. I think in the interest of time, we still have some questions, but in the interest of time, I may save them and we can always reconvene or I'm sure the audience could email us directly, but I think that's an appropriate spot to land on, that very kind of high level thought from Dr. Thamman on where things are going over the next 10 years. I can certainly say for myself, I'm very excited to see that. So in closing, I think as a physician community, it's always refreshing to get together on forums like this, to hear about each other's experiences and think about as a group how we can push healthcare forward. And virtual care in particular, which I think, and I know the panelists probably share my sentiment, that will benefit both patients and providers in the long run. I want to encourage all of you to come back to our second session entitled Scaling Virtual Cardiology. And so that'll be moderated by our Heartbeat's founder and CEO, Dr. Jeff Wessler, along with guest speakers, Drs. Andrew Freeman, Ankit Bhatia, and Dr. Rishmal Gomes. Dr. Thamman, Dr. Bhatt, Dr. Duncan, thank you so much for being here. To the audience, thank you so much. We're happy to take questions after by email, but really love the discussion today and hope this is the first of not only two, but many moving forward.